Welcome, my sleepy friends, in this quiet hour we're sharing. Tonight, we will explore something truly fascinating together. We are going to discuss antibiotics. I understand what you mean. It might be thinking, antibiotics don't sound particularly soothing, but bear with me. Because the story of how these molecules work, how they travel through your body, how they recognize their targets with almost supernatural precision, and how they've quietly saved more lives than perhaps any other medical discovery in human history. Well, that story is nothing short of extraordinary. So before we begin our journey into the invisible, take a moment to like the video to push our mission further and subscribe for more content. Also, please let me know where you are tuning in from and what time it is for you. Now let's dim the lights a little further and begin. Imagine for a moment that your body is a city. Not a chaotic metropolis, but a carefully organized community of trillions of citizens. Your cells, all working in remarkable harmony. They communicate through chemical signals. They transport resources along highways of blood vessels. They generate energy, dispose of waste, and maintain order. It's a city that never sleeps, and for the most part, it governs itself beautifully. But like any city, yours has visitors. Some are welcome. The bacteria living in your gut, for instance, numbering in the trillions themselves, are essential residents. They help you digest food, produce vitamins, and even influence your mood. They're the good neighbors, the ones who contribute to the community. But not all visitors come with good intentions. Some bacteria arrive as invaders. They breach your defenses through a cut in your skin, or they hitch a ride on contaminated food, or they slip past the barriers of your respiratory system. And once inside, they do what all living things are programmed to do. They survive, they multiply, and they compete for resources. The problem is, they're competing with you. They're stealing your nutrients, producing toxic waste products, and triggering inflammation. And if left unchecked, they can overwhelm your body's natural defenses entirely. This is where antibiotics enter the story. These are your reinforcements, your specialized tactical units, molecules designed with one purpose: to find and eliminate the invaders while leaving your own cells unharmed. It's a delicate operation requiring precision, timing, and an understanding of the fundamental differences between bacterial cells and human cells. Let's start with the most famous antibiotic of all, penicillin. The discovery of penicillin is one of those beautiful accidents that reminds us how much of science depends on noticing the unexpected. In 1928, a Scottish bacteriologist named Alexander Fleming returned from vacation to find that one of his bacterial cultures had been contaminated by mold. Most scientists would have thrown it away, grumbling about carelessness. But Fleming noticed something peculiar. Around the mold there was a clear zone where no bacteria grew. The mold, a species called Penicillium notatum, was producing something that killed bacteria. Fleming had stumbled upon the first antibiotic, though it would take more than a decade, and the work of other scientists to purify it, mass-produce it, and turn it into the life-saving medicine we know today. During World War II, penicillin became available to soldiers, preventing countless deaths from infected wounds. What had been a death sentence, a simple cut that turned septic, suddenly became treatable. The impact was staggering. But how does penicillin actually work? To understand that, we need to zoom in, way down to the cellular level, to see what makes a bacterial cell different from yours. Every bacterial cell is surrounded by a cell wall, a rigid structure made of a substance called peptidoglycan. Think of it as a protective shell, a bit like medieval armor. This wall is essential for bacteria because it prevents them from bursting. Bacteria often live in environments where water rushes into their cells through osmosis, and without that sturdy wall, they'd swell and explode like an overfilled water balloon. Your cells don't have this problem. Your cells have flexible membranes, but no rigid walls. You maintain your shape through a sophisticated internal skeleton and by carefully regulating what comes in and out. This difference, the presence of a cell wall in bacteria and its absence in human cells, is the key to how many antibiotics work. Penicillin targets the construction of the bacterial cell wall. Specifically, it interferes with enzymes called transpeptidases that bacteria use to cross-link the peptidoglycan molecules, strengthening the wall. When penicillin is present, these enzymes can't do their job. The cell wall becomes weak, full of gaps, and unable to withstand the internal pressure. The bacterium swells, the wall ruptures, and the cell dies. Your cells, lacking these walls entirely, are completely unaffected. Penicillin drifts past them like a ghost, searching only for its specific target. It's this selectivity that makes antibiotics so effective and, when used properly, so safe. Now let's follow an antibiotics journey through your body. Imagine you've developed a bacterial infection, perhaps a urinary tract infection, or strep throat, or an infected wound. Your doctor prescribes an antibiotic and you take your first pill with a glass of water. What happens next is a carefully orchestrated sequence of events that demonstrates just how sophisticated modern pharmacology has become. The pill travels down your esophagus and into your stomach. Here, it encounters an environment so acidic it could dissolve metal. Some antibiotics are fragile and quickly destroyed by stomach acid. That's why they're often coated with special layers that protect them until they reach the small intestine, where the environment is more neutral. Other antibiotics are inherently stable and pass through the stomach unharmed. Once in your small intestine, the antibiotic begins to dissolve. The molecules are absorbed through the intestinal wall and into your bloodstream. This absorption process is fascinating in itself. Some antibiotics are absorbed quickly and completely, reaching peak levels in your blood within an hour or two. Others are absorbed more slowly or only partially, which is why some need to be taken multiple times a day, while others work with just a single dose. Now the antibiotic is circulating through your bloodstream, traveling to every corner of your body. Your heart pumps it through arteries into smaller and smaller vessels, eventually reaching the capillaries, those microscopic blood vessels that weave through your tissues like threads in fabric. And here, the antibiotic begins its real work. Let's say the infection is in your urinary tract. The antibiotic molecules filter through your kidneys, concentrating in your urine, which is exactly where the bacteria have taken up residence. Or perhaps the infection is in your lungs. The antibiotic diffuses from blood vessels into the lung tissue, saturating the area where bacteria are multiplying. The medicine finds its way to the battlefield. Different antibiotics have different distributions. Some concentrate better in certain tissues. Some can cross the blood-brain barrier, that selective filter protecting your brain, while others cannot. This is why doctors choose specific antibiotics for specific infections. They're matching the weapon to the target, considering not just what bacteria they're fighting, but where those bacteria are hiding. Once the antibiotic reaches the bacteria, the molecular combat begins. We've talked about penicillin attacking cell walls, but that's just one strategy. The antibiotic arsenal is vast, and each class of antibiotics has evolved to target a different vulnerability in bacterial cells. Consider tetracyclines, a class of antibiotics that includes doxycycline and minocycline. These molecules don't attack the cell wall. Instead, they slip inside the bacterial cell and target the ribosomes, the molecular machines responsible for building proteins. Bacteria need proteins for everything: structure, metabolism, and replication. Without proteins, they can't function. Tetracyclines bind to bacterial ribosomes and jam the machinery. They prevent the ribosome from reading the genetic instructions and assembling amino acids into proteins. It's like throwing a wrench into an assembly line. The bacterium, unable to produce the proteins it needs, stops growing and eventually dies. Now here's the elegant part. Your cells also have ribosomes. You're also making proteins constantly, but bacterial ribosomes are structurally different from human ribosomes, different enough that tetracyclines can distinguish between them. The antibiotic binds tightly to bacterial ribosomes, but has very little effect on yours. Once again, it's that precision, that ability to recognize friend from foe at the molecular level that makes antibiotics possible. Or take fluoroquinolones, antibiotics like ciprofloxacin and levofloxacin. These target a different essential process, DNA replication. When a bacterial cell divides, it has to copy its entire genome, and this requires carefully unwinding the tightly coiled DNA, copying it, and then winding it back up. The enzymes that do this twisting and untwisting are called topoisomerases. Fluoroquinolones bind to these topoisomerases and freeze them in place. The DNA can't be unwound properly, can't be copied, and can't be repaired. The bacterium's genetic machinery grinds to a halt. Without the ability to replicate its DNA, the cell can't divide, can't repair damage, and ultimately dies. Again, you might wonder, don't human cells also need topoisomerases? They do, but bacterial topoisomerases are structurally distinct from human versions, and fluoroquinolones exploit those differences. The antibiotic's binding site fits the bacterial enzyme like a key in a lock, but your enzyme has a different shape, and the key doesn't fit. As you lie here listening, antibiotics might actually be working inside you right now if you're taking them, or perhaps you're remembering a time when you did. It's a strange and comforting thought, isn't it? These tiny molecules, invisible to the naked eye, navigate your bloodstream, find their targets, and carry out their mission with neither consciousness nor hesitation, just chemistry following the laws of physics. Let's talk about something that doesn't often come up in casual conversation, but is absolutely crucial to understand in antibiotics: pharmacokinetics. Don't let the term intimidate you. It simply means the study of how drugs move through your body over time. There are four main processes: absorption, distribution, metabolism, and elimination. Together they determine how effective an antibiotic will be. Absorption we've already touched on, how the drug gets from your gut into your bloodstream. Distribution is how it spreads throughout your body. But then comes metabolism, and this is where your liver plays a starring role. Your liver is the body's master chemist, a 3-pound organ with the remarkable ability to modify molecules. When antibiotics pass through your liver, enzymes attach different chemical groups to them, changing their structure. Sometimes this converts the antibiotic from an inactive form to an active one. Sometimes it does the opposite, deactivating the drug so it can be safely eliminated. This metabolic processing affects how long the antibiotic stays active in your system. Some antibiotics are metabolized quickly, their effects lasting only a few hours, which is why you take them 3 or 4 times a day. Others are metabolized slowly, maintaining therapeutic levels for 24 hours or more, allowing once-daily dosing. The dosing schedule your doctor prescribes isn't arbitrary. It's carefully calculated based on the pharmacokinetics of that particular antibiotic, ensuring that drug levels in your blood stay high enough to kill bacteria, but not so high that they cause side effects. Finally, there's elimination. Most antibiotics are removed from your body by your kidneys, filtered out of your blood, and excreted in urine. Some are eliminated through bile, produced by your liver, and released into your intestines, eventually leaving your body in stool. This elimination is why you need to keep taking antibiotics even after you feel better. The bacteria might be suppressed or weakened, but not completely eradicated. If you stop too soon, the survivors can rebound, and worse, they might develop resistance. Resistance. We need to talk about this because it's one of the great challenges of modern medicine, and understanding it helps us appreciate why antibiotics must be used thoughtfully. Bacteria are ancient organisms. They've been on Earth for billions of years, far longer than us. They've survived ice ages, asteroid impacts, and dramatic shifts in atmospheric composition. They're adaptable in ways we're only beginning to understand. And when we expose them to antibiotics, we create a powerful evolutionary pressure. Most bacteria in a population are susceptible to a particular antibiotic, but occasionally, through random mutation, a bacterium acquires a genetic change that makes it resistant. Maybe it produces an enzyme that breaks down the antibiotic. Maybe it modifies its cell wall so the drug can't bind. Maybe it pumps the antibiotic out faster than it enters. In the absence of antibiotics, this mutation might offer no advantage, or it might even be a burden. But when antibiotics are present, suddenly this resistant bacterium has a superpower. All its susceptible neighbours die, and it survives. Then it divides, passing the resistance gene to its offspring. Within hours, you have millions of resistant bacteria, where before you had one. This is natural selection in action, evolution happening at a pace we can observe in real time. It's why doctors emphasize finishing your entire course of antibiotics. When you stop early, you're most likely to leave behind the toughest bacteria, the ones that were starting to develop resistance or had higher natural tolerance. These survivors become the founding population for the next generation, and each cycle of incomplete treatment makes the bacteria a little harder to kill. Bacteria can also share resistance genes horizontally, passing them from one to another like trading cards, even between different species. A gene for resistance to penicillin can jump from one bacterial strain to another through a process called conjugation, where bacteria temporarily connect and exchange genetic material. This means resistance can spread not just through reproduction, but through community sharing. We've created a global challenge. In some regions, common infections that were once easily treatable now resist multiple antibiotics. Diseases like tuberculosis have strains resistant to nearly all available drugs. We're in an arms race, developing new antibiotics while bacteria evolve new resistances, and the uncomfortable truth is that bacteria evolve faster than we can develop new medicines. But let's not end on a dark note. Let's instead appreciate the ingenuity of the scientists working on this problem, because there are some genuinely creative solutions emerging. Some researchers are revisiting old antibiotics that fell out of favour decades ago, finding new ways to use them. Others are developing drugs that don't kill bacteria directly, but instead disable their weapons, the toxins they produce, or their ability to form biofilms, those slimy protective communities that shield bacteria from antibiotics and immune cells. There's also the exciting field of bacteriophage therapy. Bacteriophages are viruses that infect bacteria, and they're exquisitely specific. A phage that attacks E. coli won't bother staph bacteria, and vice versa. Scientists are exploring ways to use these natural bacterial predators as precision weapons, deploying the right phage against the right bacterium, a kind of biological smart bomb. And then there's the frontier of CRISPR-based approaches, where researchers program molecular scissors to cut bacterial DNA at specific locations, essentially using the bacteria's own genetic machinery against it. These technologies are still experimental, but they represent the kind of innovative thinking that gives me hope. As you lie here tonight, feeling the weight of your body against the mattress and the rise and fall of your breath, it's worth taking a moment to feel grateful for the invisible protections we have. For the fact that a simple bacterial infection, something that would have killed our ancestors as recently as a century ago, is now a minor inconvenience. For the scientists who looked at a mouldy petri dish and saw not contamination but possibility. For the chemists who decoded the structure of these molecules and learned to synthesize them. For the pharmacologists who mapped how they move through our bodies. Let's explore a few more classes of antibiotics, because each one tells us something different about the vulnerabilities of bacteria and the creativity of medicine. Aminoglycosides, like gentamicin and streptomycin, are powerful antibiotics reserved for serious infections. They work similarly to tetracyclines, binding to bacterial ribosomes and preventing protein synthesis. But aminoglycosides are particularly effective against gram-negative bacteria, those with an extra outer membrane that makes them harder to kill. Unfortunately, aminoglycosides can also be toxic to human cells, particularly in the kidneys and inner ear, which is why they're used carefully, with close monitoring of drug levels in the blood. Then there are macrolides, including azithromycin, perhaps better known as the Z-Pak. Macrolides also target bacterial ribosomes, but they bind to a different site than tetracyclines or aminoglycosides. This means they can often work against bacteria that have developed resistance to other protein synthesis inhibitors. Macrolides have the added advantage of concentrating well in tissues, making them excellent for respiratory infections. Sulfonamides represent yet another approach. These antibiotics, among the first to be discovered, interfere with bacterial metabolism. Specifically, they block the production of folic acid, a vitamin essential for making DNA. Bacteria must synthesize their own folic acid from simpler precursors. Humans don't. We get folic acid from our diet. So when sulfonamides block this metabolic pathway, bacteria starve while human cells carry on unaffected. What strikes me as particularly beautiful about all these mechanisms is how they exploit the differences between bacterial and human biology. We're all made of cells, all running on DNA and proteins and metabolism, but the details matter enormously. A slight difference in ribosome structure, the presence of a cell wall, the need to synthesize versus absorb a vitamin, these small distinctions become the cracks in bacterial armor that antibiotics can exploit. Now, I want to talk about something you might not have considered, the microbiome. Your body hosts trillions of bacteria, most of them in your gut, and they're not just passive residents. They're active participants in your health. They train your immune system, produce vitamins like K and several B vitamins, break down complex fibers into short-chain fatty acids that nourish your intestinal cells, and even produce neurotransmitters that affect your mood. When you take broad-spectrum antibiotics, those that kill a wide variety of bacteria, you don't just eliminate the invaders, you also decimate these beneficial populations. The result can be digestive upset, diarrhea, or in some cases, an overgrowth of harmful bacteria like Clostridioides difficile, which can cause serious illness. This collateral damage is why narrow-spectrum antibiotics, which target specific types of bacteria, are preferred when possible. It's also why probiotics, supplements containing beneficial bacteria, have gained popularity, though the science on their effectiveness is still evolving. What's clear is that your microbiome is resilient. It usually bounces back after antibiotics, though it may take weeks or months to fully restore the diversity that existed before. Some researchers are now developing antibiotics designed to spare the microbiome. These drugs would target specific disease-causing bacteria while leaving beneficial species untouched. It's a challenging goal, requiring deep knowledge of bacterial genetics and metabolism. but it represents the kind of precision medicine that may define the next generation of antibiotics. Let's shift our attention to how antibiotics are actually discovered and developed, because this process is far more complex than you might imagine. The golden age of antibiotic discovery was roughly from the 1940s to the 1970s. During this period, scientists screened thousands of soil samples, looking for microorganisms that produced antibacterial compounds. The strategy made sense. Bacteria in soil compete intensely with each other for resources, and many have evolved to produce chemical weapons, antibiotics, to kill their competitors. This approach yielded most of the antibiotic classes we still use today, but by the 1980s, the low-hanging fruit had been picked. Companies were screening more and more samples, but finding fewer and fewer new compounds. Many candidate antibiotics turned out to be toxic to humans or didn't work well in the body, even if they killed bacteria in a petri dish. Developing an antibiotic from initial discovery to approved drug is extraordinarily expensive and time-consuming, often taking more than a decade and costing hundreds of millions of dollars. The drug must pass through extensive testing, first in test tubes and bacterial cultures, then in cell lines and animal models, and finally in human clinical trials that progress through multiple phases, each larger and more rigorous than the last. And here's the economic paradox. Antibiotics are meant to be used briefly, typically for a week or two, and they're meant to cure the infection. This is wonderful for patients but challenging for pharmaceutical companies because it means the return on investment is much lower than for drugs treating chronic conditions that patients take for years or decades. As a result, many pharmaceutical companies have abandoned antibiotic development altogether, focusing on more profitable areas. This has created a crisis because we desperately need new antibiotics to replace the ones becoming ineffective due to resistance. Governments and international health organizations are now offering incentives, grants, prizes, guaranteed markets, to encourage companies to return to antibiotic research. There are scientists working right now, perhaps in laboratories not far from where you're listening, patiently testing compounds, analyzing data, and trying to find the next breakthrough. It's painstaking work, full of dead ends and disappointments, but driven by the knowledge that success could save countless lives. I find something deeply human and hopeful in that effort, in our willingness to invest time and resources into solving problems that won't benefit us immediately, but will protect future generations. It's the long view, the patience to play a game where the outcomes may not be known for years or decades. As your breathing has perhaps slowed and deepened during this conversation, and as your mind has followed these molecular pathways and pharmacological principles, I hope you found a kind of peace in the complexity. There's something fundamentally calming about understanding how things work, about seeing the mechanisms behind the magic. When you take an antibiotic tomorrow, or next week, or sometime in the future, you'll know what's happening. You'll know that tiny molecules are traveling through your bloodstream, finding their targets with molecular precision, exploiting the ancient differences between bacterial and human cells. You'll understand that finishing the entire course isn't just a suggestion, but a crucial step in preventing resistance. You'll appreciate the decades of research and the accumulated wisdom of thousands of scientists that went into that small pill. Let's talk briefly about some practical aspects that might interest you. How antibiotics interact with other medications, for instance. Some antibiotics affect the enzymes in your liver that metabolize other drugs. If you're taking medication for blood pressure, cholesterol, diabetes, or any chronic condition, certain antibiotics can either speed up or slow down how those drugs are processed, potentially making them more or less effective. This is why doctors and pharmacists always ask what other medications you're taking. They're not being nosy, they're checking for potential interactions. The antibiotic rifampin, used for tuberculosis, is notorious for speeding up the metabolism of numerous other drugs, including birth control pills, which is why alternative contraception is recommended during treatment. Other antibiotics, particularly fluoroquinolones, can interact with minerals. Calcium, magnesium, iron, and aluminum bind to these antibiotics and prevent their absorption. This is why you're told not to take them with dairy products or antacids. It's not that these foods are harmful, they just grab onto the antibiotic molecule and prevent it from getting into your bloodstream where it's needed. And then there's alcohol. You've probably heard that you shouldn't drink while taking antibiotics. For most antibiotics, this isn't strictly true. A glass of wine won't prevent the medication from working, but there are exceptions. Metronidazole, an antibiotic often used for dental infections and certain parasites, can cause severe nausea, vomiting, and other unpleasant reactions when combined with alcohol. And generally speaking, alcohol can worsen side effects like drowsiness or stomach upset, and it may slow your recovery by affecting your immune system and sleep quality. Speaking of side effects, let's acknowledge that antibiotics, like all medications, can have them. Most are minor, nausea, diarrhea, and mild rash. These typically resolve on their own or after finishing the medication. But occasionally, more serious reactions occur. Allergic reactions can range from mild skin rashes to anaphylaxis, a life-threatening condition requiring immediate medical attention. If you've ever been told you're allergic to penicillin, it's worth knowing that many people labelled with this allergy either never had one or have outgrown it. Childhood allergies to penicillin often don't persist into adulthood. There are now protocols for testing whether you truly remain allergic, and if you're not, it opens up treatment options that might otherwise be avoided. This matters because penicillins are often the best choice for common infections, and alternatives may be less effective or have more side effects. Antibiotics have also changed surgery. Before antibiotics, any operation carried a significant risk of infection. Surgeons in the pre-antibiotic era often had to choose between operating and watching a patient suffer from a condition they could fix, knowing that the surgery itself might introduce bacteria that would kill the patient. Today, surgical site infections are relatively rare, thanks to sterile technique and prophylactic antibiotics. Antibiotics given just before and shortly after surgery to prevent bacteria from establishing an infection. This has enabled the development of increasingly complex procedures, organ transplants, joint replacements, and cardiac surgery, all of which would be impossibly dangerous without effective antibiotics. There's something profound in realizing that so much of modern medicine rests on this foundation, that the ability to quickly and safely treat bacterial infections has enabled advances across nearly every medical specialty. Think about chemotherapy for cancer. Those powerful drugs often suppress the immune system, leaving patients vulnerable to infections. Without antibiotics to treat those infections when they occur, many cancer treatments would be too dangerous to use. Or consider premature infants in neonatal intensive care units. Their immune systems are immature, and their barriers to infection are weak. Bacterial infections are a constant threat. Antibiotics have transformed neonatal care, dramatically improving survival rates for even very premature babies. The same is true for patients with cystic fibrosis, a genetic disease that causes thick mucus to accumulate in the lungs, creating a perfect environment for bacterial growth. These patients often take antibiotics chronically or in repeated courses throughout their lives, managing infections that would otherwise destroy their lungs. Antibiotics have given us time to develop better treatments, time for patients to heal, and time for other therapies to work. They've turned death sentences into manageable conditions and made the once impossible routine. But with that power comes responsibility, individual and collective. Each time antibiotics are used unnecessarily for viral infections they can't treat, or not completed as prescribed, or given to livestock for growth promotion rather than treating disease, we add to the pressure driving resistance. Some countries have implemented strict regulations on antibiotic use, requiring prescriptions even for antibiotics that are over the counter elsewhere, and banning their use in agriculture for anything other than treating sick animals. These policies have shown results, slowing the rise of resistance in those regions. Individual actions matter too. Getting vaccinated prevents infections that might otherwise require antibiotics. Practicing good hygiene, hand washing, food safety, safe sex, reduces your risk of bacterial infections. When you do get sick, working with your doctor to determine whether an antibiotic is truly needed, and if so, taking it exactly as prescribed. These might seem like small things, but collectively they're powerful. You're part of a vast network of humans all sharing an environment with bacteria that are constantly evolving. Your choices ripple outward, affecting not just your own health but the effectiveness of antibiotics for everyone. Let me take you deeper into the world of specific bacterial infections and how antibiotics are chosen to fight them. This is where the art and science of medicine truly intersect, where doctors must balance what they know about bacteria, antibiotics, and your unique situation. Consider a urinary tract infection, one of the most common bacterial infections. The usual culprit is Escherichia coli, a bacterium that normally lives harmlessly in your intestines, but can cause problems when it enters your urinary system. For uncomplicated UTIs, doctors typically prescribe nitrofurantoin or trimethoprim sulfamethoxazole. These antibiotics concentrate heavily in urine, reaching levels far higher than in blood, which makes them perfect for infections in the bladder and urethra. Nitrofurantoin is particularly interesting. It's been around since the 1950s, yet resistance remains relatively rare. The drug works through multiple mechanisms, damaging bacterial DNA, disrupting cell wall synthesis, and interfering with various metabolic processes. This multi-pronged attack makes it difficult for bacteria to develop resistance because they'd need multiple mutations simultaneously to survive. Now consider pneumonia, an infection of the lungs. The bacteria responsible vary depending on where you acquired the infection. Community-acquired pneumonia, the kind you might develop at home, is often caused by Streptococcus pneumonia. Hospital-acquired pneumonia tends to involve more resistant organisms like Pseudomonas aeruginosa or methicillin-resistant Staphylococcus aureus, or MRSA. For community-acquired pneumonia in otherwise healthy adults, doctors often prescribe azithromycin or amoxicillin. But if you're hospitalized with severe pneumonia, you might receive intravenous antibiotics like ceftriaxone combined with azithromycin, a combination that covers a broader range of potential bacteria. The severity of your illness, your other medical conditions, and local resistance patterns, all these factors influence the choice. Skin infections present their own challenges. Simple cellulitis, where bacteria infect the deeper layers of skin, is usually caused by streptococci or staphylococci. If the infection appears to be routine staph or strep, cephalexin might be prescribed. But if there's concern about MRSA, especially if you've had it before, or if it's common in your community, you might receive doxycycline, trimethoprim sulfamethoxazole, or clindamycin instead. MRSA deserves special attention. This strain of Staphylococcus aureus has developed resistance to methicillin and related antibiotics through acquisition of a gene that produces an altered penicillin-binding protein. the antibiotic can no longer bind effectively, so the bacteria survive. MRSA infections were once confined to hospitals, but community-acquired strains have become increasingly common. Treatment options are more limited, and infections can be serious, which is why prevention, good hygiene, covering wounds, not sharing personal items, is so important. Then there's tuberculosis, caused by Mycobacterium tuberculosis, a bacterium with an unusually thick waxy cell wall that makes it resistant to many antibiotics. TB treatment requires a combination of antibiotics taken for months. The standard regimen includes isoniazid, rifampin, ethambutol, and pyrazinamide for the first 2 months, then isoniazid and rifampin for an additional 4 months. Why so long? TB bacteria grow slowly, dividing only once every 24 hours compared to every 20 minutes for E. coli. They also exist in different states within the body, actively multiplying, dormant, and everything in between. Different antibiotics work best against bacteria in different states, which is why combination therapy is essential. The lengthy treatment ensures that even the most resilient bacteria are eliminated. Unfortunately, multi-drug resistant tuberculosis has emerged in many parts of the world, requiring second-line antibiotics that are more toxic, less effective, and far more expensive. Some strains are extensively drug-resistant, leaving very few treatment options. This is resistance at its most frightening, a disease that was once curable becoming deadly again. Let's consider the phenomenon of biofilms, because this is one area where bacteria show remarkable sophistication in defending themselves. A biofilm is a community of bacteria encased in a self-produced matrix of proteins, polysaccharides, and DNA. Picture a fortress built by the bacteria themselves, with thick walls that antibiotics struggle to penetrate. Biofilms form on many surfaces. The plaque on your teeth is a biofilm, as are the slippery coatings inside your shower drain. More problematically, biofilms can form on medical devices, catheters, artificial joints, heart valves, and pacemakers. Once established, biofilm infections are incredibly difficult to treat. Bacteria within biofilms can be up to 1,000 times more resistant to antibiotics than their free-floating counterparts. Why are biofilms so resistant? Several reasons. The matrix itself acts as a physical barrier, slowing antibiotic penetration. Bacteria deep within the biofilm may be in a dormant state, not actively dividing, which makes them less susceptible to antibiotics that target growing cells. The biofilm creates chemical gradients. Nutrients and oxygen are depleted in the interior, creating microenvironments where bacteria enter survival modes that antibiotics can't touch. Sometimes the only solution is to remove the infected device entirely. A biofilm-infected artificial hip might require surgical removal, a course of antibiotics, and then reimplantation of a new joint. It's a sobering reminder that for all our medical advances, bacteria still hold some strong defensive cards. Research into disrupting biofilms is active and promising. Some scientists are developing enzymes that break down the biofilm matrix, exposing bacteria to antibiotics. Others are exploring compounds that interfere with the chemical signals bacteria use to coordinate biofilm formation, essentially preventing them from organizing their defense in the first place. Now let's talk about something that might surprise you. Antibiotics aren't always bactericidal, meaning they don't always kill bacteria directly. Some are bacteriostatic. They stop bacteria from reproducing and let your immune system finish the job. Tetracyclines and sulfonamides typically work this way. They suppress bacterial growth, holding the population in check while your white blood cells hunt down and destroy the invaders. This distinction matters when treating immunocompromised patients. If your immune system isn't functioning well, bacteriostatic antibiotics might not be enough. You need bactericidal antibiotics, ones that actively kill bacteria, because your immune system can't be relied upon to clean up the stragglers. The timing of antibiotic administration can also be crucial. In cases of sepsis, a life-threatening condition where infection triggers a cascade of inflammatory responses throughout the body, every hour of delay in administering antibiotics increases mortality risk. Emergency departments now have protocols emphasizing rapid identification of sepsis and immediate antibiotic administration, often before culture results are available, to identify the specific bacteria. This is called empiric therapy, treating based on educated guesses about which bacteria are most likely responsible, given the patient's symptoms and circumstances. Once culture results return, showing which bacteria are present and which antibiotics they're sensitive to, treatment can be adjusted. This is de-escalation therapy, narrowing from broad spectrum to more targeted antibiotics. Antibiotic stewardship programs in hospitals monitor antibiotic use, ensuring that the right drugs are used at the right doses for the right duration. These programs have successfully reduced unnecessary antibiotic use and slowed resistance development. Pharmacists trained in infectious diseases review antibiotic prescriptions, suggest alternatives when appropriate, and help ensure patients receive optimal therapy. Let me take, retry, CW, continue. You into the fascinating world of how doctors actually identify which bacteria are causing an infection, because this process is itself a remarkable piece of medical detective work. When you have a suspected bacterial infection, your doctor might order a culture. This involves taking a sample, blood, urine, sputum, or a swab from an infected area, and placing it in growth media in a laboratory. These media are carefully formulated mixtures of nutrients that bacteria need to thrive. The sample is then incubated at body temperature, and technicians wait to see what grows. Different bacteria have different requirements and preferences. Some need oxygen, others are killed by it. Some prefer acidic environments, others alkaline. By using different types of media and growth conditions, microbiologists can begin to narrow down what's present. Within 24 to 48 hours, colonies of bacteria appear, visible clusters, each descended from a single cell, now numbering in the millions. But identification doesn't stop there. The colonies are examined under a microscope after staining. The Gram stain, developed in 1884 and still used today, distinguishes bacteria based on their cell wall structure. Gram-positive bacteria retain a purple dye, appearing deep violet under the microscope. Gram-negative bacteria don't retain the dye and are counterstained pink or red. This simple test provides crucial information because gram-positive and gram-negative bacteria respond differently to various antibiotics. Further tests identify the specific species. Bacteria are exposed to different biochemical tests. Can they ferment certain sugars? Do they produce specific enzymes? Modern laboratories increasingly use mass spectrometry, a technique that identifies bacteria by their unique protein signatures in minutes rather than days. A tiny sample is vaporized and ionized, and the resulting pattern of molecular fragments is compared to a database, yielding a rapid and accurate identification. Once the species is known, the next step is antimicrobial susceptibility testing. The bacteria are exposed to various antibiotics at different concentrations to determine which drugs will work. One common method places small discs impregnated with different antibiotics on a plate spread with bacteria. Where the antibiotic is effective, a clear zone appears around the disc. Bacteria can't grow there. The size of these zones indicates how susceptible the bacteria are. The results come back as sensitive, intermediate, or resistant for each antibiotic tested. Sensitive means the antibiotic should work at standard doses. Intermediate suggests it might work at higher doses or in sites where the drug concentrates well. Resistant means the antibiotic is unlikely to be effective at safely achievable doses. This information transforms treatment from educated guessing to targeted therapy. But here's the catch. Cultures take time. Initial results might be available in 24 hours, but complete identification and susceptibility testing can take several days. For serious infections, waiting isn't an option, which is why doctors start with empiric therapy and adjust later based on culture results. There's also the reality that not all bacteria grow easily in culture. Some are fastidious, requiring very specific conditions. Some grow so slowly that standard culture techniques miss them. And some infections are deep within tissues where obtaining a sample is difficult or risky. In these cases, doctors rely on clinical judgment, imaging studies, and sometimes surrogate markers of infection like inflammatory proteins in your blood. Let's turn our attention to a class of infections that antibiotics transformed from uniformly fatal to routinely treatable. Bacterial meningitis. The membrane surrounding your brain and spinal cord can become infected with bacteria, causing inflammation and increased intracranial pressure, and without treatment, death or severe neurological damage. Before antibiotics, bacterial meningitis was a death sentence. Even with antibiotics, it's a medical emergency requiring immediate treatment. The challenge is that the blood-brain barrier, which normally protects your brain from toxins and pathogens in your bloodstream, also blocks many antibiotics from entering the cerebrospinal fluid surrounding your brain. Only certain antibiotics can cross this barrier effectively, especially when the meninges are inflamed. Ceftriaxone and cefotaxime, third-generation cephalosporins, achieve good penetration and are commonly used. Sometimes vancomycin is added to cover resistant organisms. These antibiotics are given intravenously at high doses, and treatment must begin within the first hour of arriving at the hospital. The most common cause of bacterial meningitis in adults is Streptococcus pneumoniae, and here's where vaccination enters our story. The pneumococcal vaccine has dramatically reduced cases of meningitis caused by this bacterium. Vaccination is one of our most powerful tools for preventing infections that would otherwise require antibiotics, and widespread vaccination reduces overall antibiotic use, which in turn slows resistance development. The same is true for Haemophilus influenzae type B, once a leading cause of meningitis in children. The Hib vaccine, introduced in the 1990s, has made this infection rare in vaccinated populations. It's a beautiful example of prevention being far superior to treatment, avoiding infections entirely rather than relying on antibiotics to cure them after they occur. Speaking of prevention, let's discuss prophylactic antibiotics. Antibiotics given not to treat an active infection, but to prevent one from developing. We've mentioned surgical prophylaxis, but there are other situations where this strategy is used. People with certain heart valve abnormalities receive antibiotics before dental procedures to prevent bacterial endocarditis, an infection of the heart valves that can occur when bacteria from the mouth enter the bloodstream during invasive dental work. The antibiotics are given about an hour before the procedure, achieving high blood levels precisely when they're needed to prevent bacteria from establishing an infection. Patients with recurrent urinary tract infections might take a low dose of antibiotics daily or after sexual intercourse to prevent infections. People with HIV/AIDS receive antibiotics to prevent opportunistic infections like pneumocystis pneumonia. Close contacts of someone with bacterial meningitis receive prophylactic antibiotics to prevent them from developing the disease. These uses are evidence-based and appropriate, but they do contribute to antibiotic exposure and potential resistance. It's always a balance, weighing the risk of infection against the risk of promoting resistance. Guidelines are regularly updated as new data emerges about when prophylaxis is truly beneficial and when it's unnecessary. Now let's explore what happens when antibiotics fail, when infections don't respond to treatment. Sometimes this is because the diagnosis was wrong. It wasn't a bacterial infection at all, or the bacteria are in a location the chosen antibiotic can't reach. Sometimes it's true resistance, and sometimes the infection is complicated by an abscess. An abscess is a collection of pus, dead white blood cells, bacteria, and debris walled off from surrounding tissue. It's your body's attempt to contain an infection, creating a pocket where the battle between immune cells and bacteria rages. The problem is that antibiotics penetrate abscesses poorly. The center of an abscess is often anaerobic, lacking oxygen, which changes bacterial metabolism and can make some antibiotics less effective. For many abscesses, antibiotics alone aren't enough. The abscess must be drained, either through a needle inserted under imaging guidance or through surgical incision. Once drained, antibiotics can work much more effectively against any remaining bacteria. It's a reminder that antibiotics, powerful as they are, aren't always the complete solution. Sometimes physical intervention is necessary. There's a particular challenge with prosthetic devices, artificial joints, cardiac devices, and vascular grafts. Bacteria can colonize these surfaces, forming biofilms that are nearly impossible to eradicate with antibiotics alone. In many cases, the infected device must be removed, antibiotics given for weeks or months, and then a new device implanted once the infection is cleared. It's a major undertaking, requiring multiple surgeries and prolonged antibiotic therapy, but it's often the only way to cure the infection. Let's talk about something that's becoming increasingly important: the role of the pharmacist in antibiotic therapy. Pharmacists are medication experts, and their involvement in antibiotic selection and dosing improves outcomes. They understand pharmacokinetics and can adjust doses based on your kidney function, liver function, body weight, and other factors. For antibiotics with narrow therapeutic windows, where the difference between an effective dose and a toxic dose is small, pharmacists monitor blood levels and recommend dose adjustments. This is common with aminoglycosides and vancomycin. Blood samples are drawn at specific times after a dose, levels are measured, and pharmacokinetic calculations determine the optimal dosing regimen for use specifically. Pharmacists also catch potential drug interactions. They review your medication list and flag combinations that could be problematic. They counsel patients on how to take antibiotics, with food or without, what to avoid, and what side effects to watch for. Studies consistently show that when pharmacists are integrated into healthcare teams, antibiotic use is more appropriate, outcomes improve, and costs decrease. In many hospitals, antimicrobial stewardship teams include infectious disease physicians, clinical pharmacists, microbiologists, and infection control practitioners. These teams review antibiotic prescriptions, especially for broad-spectrum or restricted antibiotics, and provide recommendations to optimize therapy. It's collaborative medicine at its best, bringing together different expertise to ensure each patient gets the right drug at the right dose for the right duration. The duration of antibiotic therapy is another area where science has evolved. For many infections, shorter courses than previously used are now known to be equally effective with fewer side effects and less pressure toward resistance. A urinary tract infection that once required 10 days of antibiotics can often be treated with 3 days. Community-acquired pneumonia might need only 5 days instead of 10 or 14. These shorter durations come from rigorous clinical trials comparing different treatment lengths. The findings challenge old assumptions and provide evidence for the minimum necessary treatment. But this isn't a universal rule. Some infections still require prolonged therapy. Endocarditis might need 6 weeks of intravenous antibiotics. Osteomyelitis, an infection of bone, might require 6 weeks to 3 months, depending on the bacteria and circumstances. The key is individualization. Your response to treatment, the specific bacteria involved, the site of infection, and your immune status all influence the optimal duration. This is why follow-up matters, why doctors want to see you after starting antibiotics, to ensure the infection is resolving and to determine when it's safe to stop treatment. Let me share something that might change how you think about antibiotics, the concept of antibiotic tolerance. This is different from resistance. A tolerant bacterium is one that stops growing when exposed to an antibiotic but doesn't die. It enters a dormant state, essentially playing dead, waiting out the antibiotic's presence. When the antibiotic is withdrawn, the bacterium wakes up and resumes growing. Tolerance is thought to contribute to persistent and recurrent infections. The antibiotic suppresses symptoms. You feel better and stop taking it, but dormant bacteria remain. Once you stop, they reactivate and the infection returns. This is yet another reason why completing the full antibiotic course is crucial. It ensures that even tolerant bacteria are exposed to the drug long enough that your immune system can eliminate them. There's also the phenomenon of persister cells. In any bacterial population, a small fraction enters a dormant state spontaneously, not in response to antibiotics, but just as a survival strategy. These persisters are extraordinarily difficult to kill because most antibiotics target actively growing bacteria. They're like sleeper agents, hiding in plain sight, and they're thought to contribute to chronic infections that are hard to cure. Researchers are investigating ways to wake up persister cells, forcing them out of dormancy so they become susceptible to antibiotics again. Some experimental approaches use compounds that stimulate bacterial metabolism, rousing persisters from their slumber just long enough for antibiotics to work. It's early-stage research, but it represents creative thinking about how to overcome bacterial survival strategies. Now let's discuss something deeply personal: the experience of taking antibiotics. You've probably taken them at some point, and you likely have memories associated with that experience. Perhaps you remember the relief of finally getting treatment for a painful infection. Or maybe you recall unpleasant side effects: stomach upset, a yeast infection, fatigue. These experiences matter. They affect whether people take antibiotics as prescribed. If you feel better after a few days, the temptation to stop early is strong. If side effects are bothersome, you might discontinue treatment. Understanding what to expect and why it's important to persevere despite side effects can make a real difference. Some antibiotics cause photosensitivity, making your skin more susceptible to sunburn. Doxycycline and fluoroquinolones are particularly notorious for this. You might not think to connect a bad sunburn with the antibiotic you're taking, but there it is. A side effect that's easily managed if you know about it. Wearing sunscreen and protective clothing and avoiding prolonged sun exposure, these simple measures prevent an uncomfortable reaction. Other antibiotics can cause tendinitis or tendon rupture, especially fluoroquinolones. This risk is higher in older adults and those taking corticosteroids. If you develop tendon pain while taking these antibiotics, stopping them immediately and consulting your doctor is essential. The risk is small, but when it occurs, it can be serious. Then there are the effects we don't see, but that matter nonetheless. Antibiotics can interfere with oral contraceptives, though this is primarily an issue with rifampin. For most other antibiotics, the interaction is minimal or non-existent, but it's still worth using backup contraception to be safe. This is the kind of practical information that empowers you to manage your health proactively. Let's explore the world of veterinary antibiotics, because the use of antibiotics in animals has significant implications for human health. Animals get bacterial infections just like we do, and they benefit from antibiotics just as we do. But the agricultural use of antibiotics, giving them to healthy livestock to promote growth or prevent disease in crowded conditions, has contributed substantially to antibiotic resistance. When animals receive antibiotics, resistant bacteria can develop in their intestines. These bacteria, or their resistance genes, can spread to humans through multiple routes: direct contact with animals, consumption of contaminated meat, and environmental contamination of water and soil. Some of the most concerning resistant bacteria, certain strains of Salmonella, Campylobacter, and E. coli, have been traced to agricultural antibiotic use. Many countries have now banned the use of antibiotics for growth promotion in livestock. The European Union did this in 2006, and antibiotic use in agriculture dropped significantly without major impacts on animal health or food production. The United States implemented similar restrictions more recently. These policy changes demonstrate that we can reduce overall antibiotic use without sacrificing animal welfare or food security. But challenges remain. In some parts of the world, antibiotics are available over the counter for both humans and animals without prescriptions. Farmers might use them preventively in crowded conditions where disease spreads easily. Aquaculture, fish farming, uses large quantities of antibiotics which enter aquatic environments and can promote resistance in environmental bacteria. Solving these problems requires international cooperation because bacteria don't respect borders. Resistant strains that emerge in one country can spread globally through travel and trade. This is why the World Health Organization has designated antibiotic resistance as one of the top threats to global health, spurring initiatives to promote appropriate antibiotic use worldwide. There's another aspect of the antibiotic story worth exploring: the role of diagnostic testing in reducing unnecessary antibiotic use. When you come to your doctor with symptoms that could be viral or bacterial, rapid diagnostic tests can sometimes provide answers within minutes. Rapid strep tests for sore throats can determine whether Streptococcus pyogenes, the bacterium that causes strep throat, is present. If the test is positive, antibiotics are warranted. If negative, the infection is likely viral and antibiotics won't help. This simple test, taking about 10 minutes, can prevent countless unnecessary antibiotic prescriptions. Similarly, rapid influenza tests can identify the flu virus, and rapid COVID-19 tests can identify coronavirus infection, both helping to rule out bacterial infections. Procalcitonin, a protein that rises in bacterial infections but not viral ones, is being used in some settings to guide antibiotic decisions, particularly for respiratory infections where distinguishing bacterial from viral causes is challenging. The more precise our diagnostics become, the more precisely we can target antibiotics. Imagine a future where point-of-care tests could identify the specific bacterium and its antibiotic susceptibilities within an hour. Empiric therapy would become much more accurate, and unnecessary antibiotic exposure would decrease dramatically. This technology is being developed right now, with some devices already in use for certain infections. As you continue to relax here, perhaps becoming drowsy, let's turn to a question you might have wondered about. Can you do anything to help antibiotics work better? The answer is a qualified yes. Staying hydrated ensures good blood flow and helps your kidneys eliminate the antibiotic at a steady rate, maintaining stable drug levels. Getting adequate rest supports your immune system, which is working alongside the antibiotic to fight the infection. Eating nutritious foods provides the building blocks your body needs to repair damaged tissue and produce immune cells. Some foods and supplements can interfere with antibiotics though. We've mentioned calcium and other minerals binding to fluoroquinolones. Grapefruit juice can interfere with the metabolism of various medications, including some antibiotics, though this isn't common. Your pharmacist can provide specific guidance about what to avoid with your particular antibiotic. Probiotics are a special case. Some people take them while on antibiotics, hoping to protect their gut microbiome. The evidence is mixed, but generally suggests modest benefit in preventing antibiotic-associated diarrhea, particularly for Clostridium difficile infections. If you choose to take probiotics, separating them from your antibiotic dose by a few hours makes sense. There's no point in having the antibiotic kill the probiotic bacteria you're trying to introduce. More important than any supplement is completing the prescribed course. This one action, taking every dose as directed for the full duration, is the single most important thing you can do to ensure the antibiotic works properly and to minimize the development of resistance. Let me bring us back to the wonder of it all. The fact that specific molecules, shaped just so, with atoms arranged in precise patterns, can seek out and destroy bacteria while leaving your cells unharmed. The fact that chemists can look at these molecular structures and predict how they'll behave in your body, where they'll go, how long they'll last, and what side effects they might cause. The fact that a contaminated petri dish led to a discovery that changed the course of human history. That World War II soldiers survived wounds that would have killed their grandfathers. That a child today with a bacterial ear infection receives a prescription and feels better in days, never knowing how different their experience would have been a century ago. This is the legacy of antibiotics, a gift from previous generations of scientists and healthcare workers who dedicated their lives to understanding disease and developing treatments. Their work continues in laboratories and clinics around the world in the efforts to preserve antibiotic effectiveness and develop new approaches to fighting infection. You are the beneficiary of this accumulated knowledge. When you need antibiotics, you stand on the shoulders of giants, Fleming, Florey, Chain, Waxman, and countless others whose names aren't widely known, but whose contributions were no less important. As you lie here now, your body continues its constant work. Your immune system patrols, your microbiome maintains its delicate balance, and your cells divide and die and are replaced in their billions. You are an ecosystem, a walking world of interactions between human and microbial cells, mostly peaceful, occasionally requiring intervention. Antibiotics are there when needed, tools in the medical arsenal to be used wisely and gratefully. They remind us of our fragility, but also our resilience, of the threats we face, but also our capacity to meet them with intelligence and creativity. The next time you take an antibiotic, pause for a moment. Hold the pill in your hand and appreciate the journey it represents, from soil bacteria competing for resources, through decades of research and development, through rigorous testing and regulatory approval, to your local pharmacy, and finally to you. Each pill is a small miracle of modern science, a molecule designed with one purpose: to help you heal. Tonight, as sleep approaches, let yourself feel gratitude for this protection, for the invisible defenses working on your behalf, for the knowledge that if bacterial invaders breach your borders, treatments exist that your great-grandparents could never have imagined. Let your breathing slow. Let your muscles relax completely. Let the complexity and beauty of pharmacology fade into peaceful darkness. You are safe, protected by layers of defense, both natural and pharmaceutical, and cared for by generations of scientific progress. Rest well. The antibiotics, if ever you need them, will be there. And the scientists continue their work, ensuring they remain effective for you and for generations to come. Good night. We're starting a very personal journey of discovery. Sleep pharmacology isn't just about drugs and pills. It's also about figuring out how chemistry and consciousness, molecules and dreams work together. We'll learn how a small pill can talk to your brain, how your liver becomes a master chemist at night, and how your body changes things that aren't yours into ways to get some sleep. Picture, if you will, that your body is an old city at dusk. The streets are like your blood vessels, moving people and messages to every corner. The buildings are like your organs, each with its own job and rhythm. There are billions of people in the world, and they all have their own part to play in the grand symphony of life. And a visitor comes to this city with a promise of sleep. It could be a small blue pill or a clear liquid. What happens next is nothing short of amazing. A story of molecular recognition, chemical change, and biological knowledge that has been honed over millions of years. You start your journey the moment you put that medicine on your tongue. People don't often talk about how drugs work in the mouth, but it's actually the first place our bodies check for drugs. There are tiny blood vessels, called capillaries, that run through the warm, moist area under your tongue. These capillaries are so fine that they look like silk threads woven just below the surface. Scientists call these vessels the sublingual route, which means under the tongue. They offer something very special. Some drugs, especially those that are meant to work quickly, can go right through this thin membrane and into your bloodstream without having to go through your digestive system first. It's a fast track, a VIP entrance to your circulation that can get medicine to your brain in just a few minutes, instead of the hour or more it might take through the stomach. The tissue here is very permeable, which helps us taste and judge food. Now, it also acts as a gateway for medicine. Your saliva is also very important in this first act. This clear fluid comes from 3 pairs of major salivary glands that are hidden around your jaw. It's not just water with some minerals in it. It's a complicated mix of enzymes, proteins, and electrolytes that are all carefully balanced to start the digestion process. These enzymes start working right away when a drug dissolves in your saliva. They can either activate the drug or start breaking it down. The pH level of your saliva, whether it's slightly acidic or alkaline, can affect how quickly some medicines dissolve and are ready to be absorbed. But most sleep medications take the long way around, going down your esophagus in a way that is more complicated than it seems at first. Your esophagus isn't just a tube, it's a muscular tube that moves food and medicine down by using coordinated contractions called peristalsis. These wave-like movements happen automatically and without you having to think about them. They make sure that your medicine gets to your stomach quickly, even if you take it while lying down. The environment in your esophagus can change how well medications are absorbed in small ways. The temperature here is very close to your core body temperature, which is about 98.6 degrees Fahrenheit. This affects how quickly solid medications start to dissolve. Most of the time, liquids only take a few seconds to get through, and pills take 10 to 15 seconds. This means that most of the absorption here is very low, but it's not zero. Some medicines can start to enter your bloodstream even during this short passage. The real change starts when the food gets to your stomach. Your stomach isn't just a simple container, it's a complex chemical lab. It's a muscular sac lined with specialized cells that have evolved to break down everything from tough plant fibers to complex proteins. The stomach juices here are a great example of biological engineering. They have hydrochloric acid that is strong enough to break down metal, but they are carefully buffered and controlled so that they don't hurt your own tissues. The pH of this acidic environment is usually between 1.5 and 3.5, and it serves several purposes in the processing of medications. Some drugs are made to dissolve quickly in this acidic bath. Their outer coatings are made to break apart quickly when they come into contact with stomach acid. Some, on the other hand, are made to not dissolve here. Instead, they are made to go through the whole stomach and dissolve in the small intestine, which is more alkaline. Your stomach's temperature is close to your body's core temperature, which is the best temperature for the enzymatic reactions that start to break down some drugs. Pepsin, the main enzyme in the stomach that breaks down proteins, can also interact with some drugs, especially those that are made of proteins or have protein parts. This isn't always good. For example, pepsin can make some medications less effective. That's why some drugs are made with special coatings to protect them while they are in the stomach. The way your stomach contracts and relaxes affects how well drugs are absorbed. When your stomach is empty, it contracts strongly every 90 to 120 minutes, pushing any leftover particles toward the small intestine. Scientists call these moving motor complexes migrating motor complexes. They can change when and how medicines leave your stomach. A pill taken during one of these contraction phases might be quickly whisked away, while one taken during a quiet period might stay around longer, which could change how much of the drug is absorbed. When you have food in your stomach, the way drugs work is completely different. A meal, especially one with a lot of fat, can make your stomach empty much more slowly, keeping medicines in your stomach for hours instead of minutes. Some drugs, like those that irritate the stomach lining, can benefit from this delay, but for others, like those that need to get to the small intestine quickly to be absorbed properly, it can be a problem. Think of these extended-release tablets as little time capsules. They are amazing pieces of pharmaceutical engineering that are the result of decades of research into how to control drug delivery. Engineers have made them with layers that dissolve at different rates, like an onion made of medicine, but this simple comparison doesn't do them justice. Some use osmotic pressure, which has a small chamber that slowly fills with fluid and pushes the medicine out through a hole drilled by a laser at a very controlled rate. Some people use matrix tablets, which are made of a polymer that slowly breaks down or lets the drug spread out over time. These advanced delivery systems aren't just for convenience. They also work with your body's natural rhythms. There are many stages of sleep, from light sleep to deep slow wave sleep to the dreaming stages of REM sleep. You can make extended release formulations that give you medicine during these different phases, so you don't wake up at 3 in the morning when the first dose has worn off. Most medicines go from your stomach to your small intestine, where they really start to work. The small intestine is a long tube that is folded up in your abdomen like an origami masterpiece of biological engineering. It is about 20 feet long. More importantly for drug absorption, the inside of your stomach is covered in millions of tiny finger-like projections called villi. Each villus has even smaller projections called microvilli on top of it. This makes a surface area about the size of a tennis court, all in the small space of your abdominal cavity. Most drugs move from the outside world into your internal circulation through this huge area of absorptive surface. There is nothing random or haphazard about the process. It follows complex biological rules that have been honed over millions of years of evolution. There are special transporters in your intestinal cells that act like tiny molecular doormen. They only let certain things through and keep others out. There are different types of these transporters, and each one has its own strengths. Some are passive, which means that molecules can move down concentration gradients like water flowing downhill. Some, on the other hand, are active and use cellular energy to move molecules across the intestinal barrier, even against concentration gradients, like a molecular escalator moving things up. Some of them help by speeding up the movement of certain molecules that would otherwise move slowly on their own. Our story needs to talk about the P-glycoprotein transporter. This amazing protein works like a biological bouncer, pushing some drugs out of intestinal cells and back into the intestinal lumen, which lowers their absorption. It has been around for a long time and has changed over time to protect us from plant toxins and other harmful things we might eat. But in today's world of drugs, it can sometimes work against us, making helpful drugs less effective. The different parts of your small intestine absorb things in different ways. The duodenum, which is the first part of the small intestine after the stomach, is where most of the iron and calcium are absorbed. It also helps with drug absorption, especially for drugs that are acidic. The jejunum, which is in the middle, is where most of the nutrients and many of the medicines are absorbed. The ileum is the last part of the small intestine. It has special transporters for vitamin B12 and bile acids, but it also helps drugs get into the body, especially those that are meant to be released slowly. Blood flow to your intestines changes throughout the day in ways that can affect how well drugs work. After you eat, blood flow to the intestines increases a lot to help the body absorb nutrients. This improved blood flow may also help the body absorb medicines better, which could make them work better when taken with food. On the other hand, when you're under a lot of stress or doing a lot of physical activity, blood flow to the intestines slows down because your body sends blood to muscles and vital organs instead. This could make drugs less effective. As you move from the duodenum to the ileum, the pH of your intestines changes slowly from slightly acidic to more alkaline. This change in pH affects where different medicines can be absorbed. The lower small intestine is more alkaline, which makes it easier for basic drugs to get into the body. The duodenum, on the other hand, is more acidic, which makes it easier for acidic drugs to get into the body. When pharmaceutical chemists make drug formulations, they use these differences to their advantage. For example, they might make enteric coatings that only dissolve at certain pH ranges. Once medicines pass through the wall of the intestines, they don't go right into your bloodstream. First, they have to go through the portal circulation, which is a special blood vessel system that moves blood from the intestines straight to the liver. This portal system checks the quality of the substances that your gut absorbs and makes sure that the liver processes them before they can get to the rest of your body. First-pass metabolism is the first time a drug goes through the liver. It can have a big effect on how much of the active drug gets into your bloodstream. During this first encounter with the liver, some drugs are broken down so much that only a small amount of the original compound is left to have therapeutic effects. This is why some drugs that work well when injected don't work when you take them by mouth. They get broken down in the liver the first time they go through it. The liver, which is about 3 pounds and sits under your right ribs, quietly plays the role of the main pharmacist in your body's drug drama. This amazing organ is made up of functional units called lobules. Each lobule is a hexagonal arrangement of liver cells called hepatocytes. The liver is where most drugs are broken down in the body because it has the most drug metabolizing enzymes. Our story should give special attention to the cytochrome P450 enzyme system. The names of these enzymes, like CYP3A4, CYP2D6, and CYP1A2, sound technical, but they are the molecular machinery that breaks down most of the drugs we take. These enzymes can do amazing things to chemicals, like adding oxygen atoms, taking away chemical groups, or breaking up big molecules into smaller pieces. It's interesting that these enzymes didn't evolve to break down modern drugs. Over millions of years, they evolved to help our ancestors get rid of plant compounds, environmental toxins, and other things that weren't from their own bodies. It's a happy coincidence that they can effectively process modern synthetic drugs. This may also show that all organic chemistry is basically the same, whether it happens in plants, labs, or living things. Your liver doesn't work at the same speed all day. It follows circadian rhythms, which are internal clocks that sync up biological processes with the cycle of day and night. This is true for almost every organ in your body. Drug metabolizing enzymes work differently at different times of the day. They are usually most active during the day, when we are most likely to be eating and coming into contact with new substances, and less active at night, when we are sleeping and fasting. This change in liver function over the course of a day is why taking the same dose of a sleep aid at different times might have slightly different effects. Your liver's internal biological clock may process a dose taken at 10 p.m. differently than one taken at midnight. This is not only because of when you go to sleep. In the field of chronopharmacology, which studies how biological timing affects drug action, it is becoming more and more important to understand these rhythms. The liver's processing of drugs does more than just get rid of them. The liver can change a prodrug, which is an inactive form of a drug, into its active form. These prodrugs are like Trojan horses for drugs. They are inactive compounds that the liver changes into their active forms only after they have been absorbed and processed. This method can help drugs get into the body better, lower the risk of side effects, or give you more control over when and where a drug becomes active. Sometimes, the liver starts to get drugs ready for removal by adding chemical groups that make them easier for your kidneys to filter out of your body. This process, known as conjugation, adds small molecules like sulfate groups or glucuronic acid to the drug. This makes it easier for your kidneys to find and get rid of the drug. The fact that liver enzymes can be different from person to person makes our story about drugs even more complicated. Each of us gets a slightly different set of the genes that code for enzymes that break down drugs, and these genetic differences can have a big impact on how we react to drugs. Some people are genetically programmed to be extensive metabolizers, which means they break down certain drugs so quickly that normal doses don't have much of an effect on them. Some people are poor metabolizers, which means they don't have functional copies of important enzymes and process drugs so slowly that even small doses can have strong and long-lasting effects. This genetic lottery explains why both patients and healthcare providers sometimes have trouble with how medications work. The sleep aid that works perfectly for your friend might not work at all for you, or vice versa. This is not because your sleep problems are different, but because the enzymes that break down the medicine are different. After your liver processes them, medications travel through your bloodstream on a very advanced transportation network. Your blood isn't just a simple fluid. It's a complicated mix of water, proteins, electrolytes, and many other dissolved substances that are all carefully balanced to keep you alive. Blood has proteins that can bind to drugs, and albumin is one of the most important ones for drug transport. You can think of albumin as a taxi service for molecules. A lot of medicines, especially those that dissolve in fat, stick to albumin as they move through your blood. This binding has a number of important jobs. It stores medicine that can be released when needed, helps move medicine to tissues in your body, and stops your kidneys and liver from quickly getting rid of medicine. Drugs and albumin don't stay together forever. They are in a dynamic equilibrium, with drug molecules constantly binding to and releasing from albumin as they move around. The only medication that is pharmacologically active is the free medication that is not bound to anything. This means that it can leave the bloodstream and interact with tissues. This means that things that affect albumin levels or binding capacity can change how well a drug works. Age, illness, and nutritional status can all change the levels of albumin and how well it binds to other substances. Older adults frequently exhibit diminished albumin levels, which may elevate the concentration of free active drug in their circulation. People with liver disease may not make as much albumin, and people with kidney disease may lose albumin in their urine. These changes can have a big effect on how medications work in the body, and they may need to be adjusted. Your blood carries drugs to every tissue, organ, and cell in your body, but not every place is happy to see them. Blood flows at different rates through different tissues, and they have different binding capacities and affinities for different drugs. Some drugs like fatty tissues a lot, and they build up in adipose tissue like molecular tourists who are drawn to a nice resort. This tissue distribution isn't random. It follows patterns that can be predicted based on the chemical and physical properties of the tissues and the medication. Lipophilic drugs, which dissolve easily in fats, tend to build up in fatty tissues. Your brain is about 60% lipid by dry weight. This isn't a coincidence. For sleep medications, this is exactly what we want in terms of brain distribution. Because of the blood-brain barrier, your brain is a unique challenge for getting medicine to it. This barrier isn't just a wall. It's a smart, active system that keeps harmful substances away from your most important organ. The capillaries in your brain are different from those in the rest of your body. The cells are tightly connected, which keeps most things from just squeezing through gaps. There are special transporters in the blood-brain barrier that control what goes in and out of brain tissue. Some of these transporters are friendly to certain drugs and carry them across the barrier with molecular hospitality. Some of them act like bouncers, actively pumping foreign substances back into the bloodstream to keep them from getting into the brain. How well a drug can get to its brain targets depends on how well these two transport systems work together. Sleep medications are made to get past this protective barrier. They often use molecular mimicry to make themselves look like natural substances that the brain normally welcomes. Some pretend to be neurotransmitters, while others pretend to be amino acids. They get past the brain's defenses and go to their intended targets in neural tissue. When sleep drugs get into your brain, they have to deal with a very complicated environment. Your brain has about 86 billion neurons, and each one is connected to thousands of others by synapses. This makes a communication network that is bigger than any system made by humans. The molecules of the medicine move through this neural matrix like molecular snow, eventually finding and attaching to their specific target receptors. GABA receptors are the most common targets for sleep medications. Learning about these receptors shows how well-designed pharmaceuticals can be. Gamma-aminobutyric acid, GABA, is the main inhibitory neurotransmitter in your brain. In other words, it's the brain's slow-down signal. GABA opens channels that let chloride ions into neurons when it binds to its receptors. This makes the neurons less likely to fire and send signals. But GABA receptors aren't the same all over your brain. They have different types, each with its own set of characteristics and locations. Most sleep medications work by targeting the GABAA receptors, which are very complicated themselves. 5 protein subunits make up each receptor, and they are arranged around a central channel. There are many different types of each subunit. This complexity isn't just for school. It has real-world effects on how sleep medications work and what side effects they might have. Receptors have different properties depending on how the subunits are put together. Some are mostly found in parts of the brain that control sleep and wakefulness, while others are found in parts that control anxiety, and still others are found in circuits that control memory formation or muscle coordination. Modern sleep medications are increasingly designed to exploit this receptor diversity. Newer drugs are made to only affect certain receptor subtypes, rather than just making GABA work better all over the brain. A drug that only affects receptors in brain areas that control sleep, and not those that control memory, might help people sleep without making memory problems worse, as older sleep aids can do. When a sleep medication binds to its receptor, it starts a chain reaction of molecular events in the brain cell. The receptor changes shape, which makes its central channel wider or keeps it open longer than GABA would on its own. More chloride ions enter the cell, which makes it even less likely to fire. Like a whisper going through a crowd, the effect spreads through connected neural circuits, slowly slowing down the brain activity that keeps us awake and aware. Pharmacologists call these receptor interactions dose-response relationships. Only the most sensitive receptors are affected at low doses, which makes people feel a little calmer. As the doses go up, more receptors are used, and the effects become stronger. Eventually, at very high doses, enough receptors are affected that consciousness is lost completely. This is the idea behind general anesthesia, which uses drugs that work on similar receptor systems but at much higher concentrations. Different sleep medications have different times and lengths of receptor binding. Some bind and break apart quickly, which means they work quickly but don't last as long. Some bind more slowly but stay in place longer, which makes the effects last all night. Still others have a slow metabolism that slowly lowers their receptor binding over time. This lets them wake up naturally without the sudden end that can cause rebound insomnia. Your brain's reaction to sleep drugs isn't always the same. It changes over time as you take them more often. Your brain slowly gets used to sleep medication because of neural plasticity, which is the brain's ability to change and reorganize itself. There may be fewer receptors may become less sensitive, or compensatory systems may become more active. This neuroadaptation is what makes tolerance possible. It explains why some people need higher doses over time to get the same sleep-promoting effects. In the meantime, your kidneys have quietly started their own important work in our pharmaceutical drama. These paired bean-shaped organs are about the size of your fist and are located on either side of your spine just below your rib cage. They are some of the hardest working organs in your body. About 50 times a day, they filter all of your blood, which is an amazing feat of biological engineering that is better than any man-made filtration system. There are about 1 million nephrons in each kidney, and each nephron is a tiny work of biological art. A glomerulus is a group of tiny blood vessels that make up the nephron. It is wrapped in a cup-shaped structure called Bowman's capsule. As blood moves through the glomerulus, pressure pushes fluid and small molecules through the capillary walls and into the capsule. This makes an ultrafiltrate of blood. This first filtrate has not only waste products, but also useful things like glucose, amino acids, vitamins, and, most importantly for our story, medicines, and what happens to them when they break down. The filtrate then goes through a long twisted tube where the kidney does its real work. Different parts of this tube are good at reabsorbing different things. Almost all of the glucose is taken back, most of the amino acids are taken back, and the water and electrolytes are carefully balanced. This tubular system offers both benefits and drawbacks for medications. Water-soluble drugs and their metabolites can be easily filtered at the glomerulus. If they are not reabsorbed, they will be excreted in the urine. Fat-soluble drugs, on the other hand, are more likely to be reabsorbed into the blood as the filtrate moves through the kidney tubules. This makes it harder to get rid of them. To deal with this problem, the kidney has developed very advanced transport systems. Active transport pumps in the kidney tubules can take certain molecules from the blood and put them into the urine, even when there are more of them in the blood than in the urine. This means that they are working against concentration gradients. These pumps use energy from cells, but they help the kidney get rid of things that might build up in the body. These transport systems work with different medications in different ways. Some are substrates, which means that the pumps move them and get rid of them faster than passive filtration alone would suggest. Some are inhibitors, which stop the pumps and could cause other substances to build up. Some are both substrates and inhibitors, which makes for complicated interactions that need to be thought about carefully when more than one medication is used together. Your urine's pH level is an interesting part of how drugs leave your body. Depending on what your body needs, your kidneys can change the pH of your urine from very acidic to moderately alkaline. This pH control has an effect on how well weak acids and weak bases are removed from the body. Basic drugs tend to get stuck and leave the body more easily in acidic urine, while acidic drugs are more likely to be reabsorbed. In alkaline urine, the opposite happens. This elimination that depends on pH can be important in a clinical setting. Your urine's pH can change because of changes in your diet, certain diseases, or other medications. This can change how quickly sleep medications leave your body. A diet high in protein tends to make urine more acidic, while a vegetarian diet tends to make it more alkaline. These dietary effects usually aren't big enough to need changes in the dose of medication, but they do add to the fact that people respond to drugs in different ways, which makes pharmacology both hard and interesting. Your kidneys also follow circadian rhythms, which means they filter and get rid of things at different rates during the day. Your body's internal clock affects the flow of blood to your kidneys, the rate at which they filter blood, and the activity of transport pumps. Kidneys usually work harder during the day and slower at night. This can change how long medications stay in your body depending on when you take them. When thinking about how the kidneys get rid of drugs, the idea of drug half-life becomes very important. Half-life is the amount of time it takes for half of a drug to leave your body. It is one of the most important things that affect how often you need to take a drug and how long its effects will last. A drug with a short half-life is quickly removed from your body, so you need to take it often, but it also clears out of your system quickly. A drug with a long half-life stays in your body longer, so you don't have to take it as often, but it could have longer lasting effects. Half-life is very important for sleep medications because it tells you what will happen the next day. A sleep aid with a very short half-life might help you fall asleep, but it might wear off too quickly, waking you up in the middle of the night. One that lasts a long time might help you sleep through the night, but make you feel tired the next morning. The best sleep medicine would have a half-life that matches how long you want to sleep. It should last all night but be mostly gone by morning. Differences in how well each person's kidneys work can have a big impact on how drugs are broken down, and, as a result, their effects. As we get older, our kidneys don't work as well. After age 40, they usually lose about 1% of their capacity each year. This decline that comes with age means that older people get rid of many medications more slowly, which may mean they need lower doses or less frequent dosing to avoid side effects and build-up. Kidney disease, even in its early stages, can have a big impact on how well medications are cleared from the body. People whose kidneys don't work as well may build up drugs that the kidneys mostly get rid of, which could cause effects that are too strong or last too long. Because of this, doctors often change the doses of medications based on how well the kidneys are working. They do this by doing blood tests that measure creatinine or estimate glomerular filtration rate. You might be surprised to learn that how hydrated you are affects how well your kidneys work and how quickly drugs leave your body. Dehydration slows down blood flow to the kidneys and may make it harder for some drugs to leave the body. On the other hand, drinking enough water helps the kidneys work better and get rid of drugs. This is one reason why doctors often tell their patients to drink enough fluids. However, for sleep medications taken at night, there is a clear balance to be struck between helping the kidneys work properly and not having to go to the bathroom in the middle of the night. When you take more than one medication, they can interact with each other in complicated ways that create a web of pharmaceutical relationships in your body. The systems that get rid of drugs are the most complicated of all. If you take more than one medicine, they don't just work on their own. They also fight for the same elimination pathways, like cars trying to get onto a busy highway. This competition can have important effects on health. If two drugs are both substrates for the same kidney transport pump, they might compete for elimination, which could cause both of them to build up to higher levels than expected. If one drug stops a transport pump from working and another drug needs that pump to get rid of itself, the second drug could build up to dangerous levels. These drug-drug interactions aren't just things that doctors worry about. They're real situations that doctors need to think about when giving patients more than one medication. If you take a sleep aid by itself, it might work perfectly, but when you take it with other drugs that change how it is absorbed, metabolized, or eliminated, it might not work as well. There are also things that may not seem like they have anything to do with pharmacology that can affect how your body reacts to sleep medications. Your circadian rhythms, which are the internal biological clocks that control everything from hormone release to body temperature, have an effect on how drugs are absorbed, distributed, metabolized, and removed. Taking the same medicine at different times of the day can change how much is in your blood, how it works, and how long it lasts. Chronopharmacology is the study of how biological timing affects drug action. It is becoming more and more clear that this is important for getting the most out of medication therapy. At night, your stomach empties more slowly than during the day. This could change how quickly oral medications are absorbed. Your liver breaks down drugs differently when you're awake than when you're asleep. Your blood flow changes throughout the day, which affects how medicines get to different tissues. This time-related part of pharmacology is especially important for sleep drugs. Most of the time, you take these drugs at night, when your body is getting ready for sleep, which is when it heals itself. Your heart and blood vessels are slowing down, your digestive system is becoming less active, and your brain is starting to make the complicated neurochemical changes that help you sleep. The sleep medicine becomes a part of this natural change, working with your body's own sleep-promoting processes instead of against them. Another interesting connection between sleep physiology and pharmacology is how temperature affects sleep. When you sleep normally, your core body temperature drops. This change in temperature affects how medications are absorbed and spread throughout the body. Your body's blood flow patterns change when it tries to keep heat in, which could change how quickly medicines get to their target tissues. Some sleep medications may actually make this natural drop in temperature stronger, which is one of the ways they help people sleep. The way sleep medications affect your body's natural sleep architecture shows how complex the interaction is between drugs and biological processes. Normal sleep isn't just being unconscious, it's a complex state that goes through different stages, each with its own traits and purposes. Stage 1 and Stage 2, non-REM sleep, also called light sleep, is the first step toward deeper sleep. Your brain waves start to slow down, your muscles stop working as hard, and your awareness slowly fades during these stages. Some sleep medications mainly work on the lighter stages of sleep, making it easier to go from being awake to being asleep, but they don't always make sleep deeper or longer. Slow-wave sleep, also known as deep sleep, has brain waves that are very slow. It is thought to be very important for restoring the body, strengthening memories, and keeping the immune system healthy. Some sleep medications can actually stop this stage of sleep, which is strange because you might feel like you've slept well, but not gotten all the benefits of natural deep sleep. There are several cycles of REM sleep throughout the night, with longer and more intense REM periods in the morning. This is the stage of sleep when you have vivid dreams. This stage is very important for controlling emotions, processing memories, and growing the brain. Some sleep medications make REM sleep less likely to happen, while others have no effect on it at all. A few sleep medications may even make REM sleep last longer or be more intense. The occurrence of REM rebound exemplifies the intricate interplay between pharmacological agents and innate sleep mechanisms. When people stop taking sleep medications that keep them from having REM sleep, they often have a lot of very intense, frequent, or vivid dreams for a few nights, as their brain catches up on the REM sleep it missed. This rebound effect can be scary for people who don't expect it, but it's actually a sign of how well the brain can regulate itself and bring things back into balance. Sleep medications can also change the way the body naturally moves between different sleep stages. Normal sleep follows a pattern that can be predicted. Throughout the night, there are cycles of light sleep, deep sleep, and REM sleep. Some medications can mess up this natural cycle, which can make sleep feel less refreshing, even if you get enough sleep overall. When you think about how these drugs affect sleep architecture, the timing of when you take them becomes very important. If you take a medicine too early in the evening, it might work best before you're ready to sleep, which could make you sleepy too soon or make it hard for you to finish your evening tasks. If you take one too late, it might not work at its best until the middle of the night, which could make you sleepy the next day because the drug keeps working after you want to sleep. Different people have different sleep needs and patterns, which makes using sleep medications even more complicated. Some people are larks by nature, which means they like to go to bed early and wake up early. Others are owls, which means they like to stay up late and sleep in the morning. These chronotype differences aren't just preferences. They're real differences in how our internal biological clocks work, and they can change how sleep medications work. A drug that works well for someone who naturally stays up late might not work as well for someone who has an early chronotype. This isn't because the drug's pharmacology is different. It's because the person's brain is naturally ready for sleep at different times. The best sleep medicine is one that works with your body's natural sleep-wake cycles, not against them. There are many environmental factors that are often overlooked but can be clinically important in this pharmaceutical story. The temperature in your bedroom affects not only how comfortable you are, but also how well medications work and how they spread. Some medicines may take longer to work in cooler temperatures, while others may work faster in warmer temperatures. The amount of moisture in the air can affect how well some formulations dissolve, or how well transdermal medications are absorbed through the skin. Light exposure, especially at night, can make sleep medications work in strange ways. Bright light in the hours before bed can stop your body from making melatonin, which could make sleep medications less effective. On the other hand, dim light or darkness can make sleep aids work better by letting your body's natural sleep-promoting systems work with the medicine. The height at which you live can also affect how your body breaks down and uses medicine. When you go to higher altitudes, the lower oxygen levels can change how quickly medications are broken down by the liver. The lower air pressure can also change how well inhaled drugs work, but this is less important for most sleep aids. The social and psychological context of medication use adds another layer to our story. Taking a pill, especially one that a doctor you trust gives you, can cause changes in brain chemistry that can be measured. This is what we call the placebo effect, but calling it just a placebo effect makes it seem less important. This is a real neurobiological response that can make active drugs work better. If you think you're going to be sleepy, your body may release its own sleep-promoting chemicals. Your brain can get ready for sleep by making taking your medicine a part of your daily routine. The bedroom, the bedtime routine, and even the act of turning off the lights and getting into bed all play a role in the complex neurochemical cascade that helps people sleep. Sleep medications work within this larger context rather than on their own. The social aspects of using sleep medications also have an effect on how well they work. Stress from family, work, or health can trigger your body's stress response systems, which release cortisol and adrenaline that work against the effects of sleep medications. On the other hand, feeling safe and calm can make medication work better by letting your body's natural sleep systems work at their best. People's cultural views on sleep and medicine can affect whether or not they choose to use sleep aids and how well they work. In cultures that look down on sleep problems or medication use, people may feel anxious about taking sleep aids, which can make them less effective. On the other hand, when using sleep medications is normal and supported, people may have better results because they are less anxious and have higher expectations. When you stop taking sleep medications, it shows how adaptable your body's neurochemical systems are. If you've been taking a sleep aid regularly, especially one that boosts GABA activity, your brain slowly changes its natural chemistry to keep things in balance when the outside chemical is present. Your brain might try to keep working normally, even though a drug that boosts GABA is always there. This could mean that neurons make less GABA, or that GABA receptors become less sensitive. This neuroadaptation becomes a problem if you suddenly stop taking the medicine. Your brain is making less of the chemicals that help you sleep and has fewer or less sensitive receptors to respond to them. The result can be rebound insomnia, which is when you have trouble sleeping that is worse than the problem that made you take the medicine in the first place. This rebound effect usually goes away as your brain gets used to working without the medicine, but it can take days to weeks and be very uncomfortable. This neuroadaptation helps us understand why doctors often suggest slowly lowering the dose of sleep medications instead of stopping them all at once. This tapering process gives your brain time to slowly change its natural chemistry, which helps lessen withdrawal symptoms and the chance of having severe rebound insomnia. The idea of kindling gives us a new way to think about sleep medication withdrawal. This phenomenon, initially identified in seizure studies, pertains to the brain's increasing sensitivity to withdrawal effects following successive cycles of medication administration and cessation. When someone stops and starts taking sleep medicine again, the withdrawal symptoms may get worse, and it may take longer for the brain to get used to it again. This isn't a punishment for taking medication, it's just how neural plasticity works. Knowing this can help explain why taking medication consistently and with care is often better than taking it only when you need it. Your gut microbiome, which is the huge ecosystem of bacteria, fungi, and other microorganisms that live in your intestines, has a surprisingly big effect on how well sleep medications work. Researchers are just starting to figure this out. These tiny creatures don't just hitch a ride, they also take part in your body's chemistry, including how your body breaks down the drugs you take. Some types of bacteria can break down certain drugs, which could lower the amount of active medication that gets into your bloodstream. Some people make their own neuroactive chemicals, like GABA, serotonin precursors, and other chemicals that can change sleep and mood. The bacteria in your gut microbiome and how much of each type you have can affect how well sleep medications work for you. This microbiome makeup isn't set in stone. Diet, stress, illness, antibiotic use, and age all affect it. If someone has recently taken antibiotics, their microbiome may have changed in a way that makes it process drugs differently than usual. A person with digestive problems might have a microbiome that changes how drugs are absorbed or broken down. The time of meals in relation to taking medicine can also affect which bacteria are most active and how they might interact with drugs. The gut-brain axis is a two-way communication network between your brain and your digestive system. It adds another layer to this story. Your gut makes a lot of the same neurotransmitters as your brain, like serotonin, dopamine, and GABA. When sleep medications change the chemistry of the brain, they can also change how the gut works. Changes in gut chemistry can also change how the brain works and how well medications work. Stress is a great example of how psychological factors can affect drug outcomes through biological means. Your hypothalamic pituitary adrenal axis turns on when you're anxious or worried, releasing hormones like cortisol and catecholamines like epinephrine and norepinephrine. These stress hormones don't just change how you feel, they also change how drugs are broken down, absorbed, and work. Stress that lasts a long time can make some liver enzymes work harder, which could make medications break down faster and be less effective. Acute stress can change how medications are absorbed by changing how quickly the stomach empties and how blood flows through the intestines. Stress hormones can also directly block the effects of sleep medications at their target receptors, which means that your body's stress response and the medication's sleep-promoting effects are basically fighting each other. The connection between pain and sleep medications is another example of how different physiological systems can work together in complicated ways. Pain and sleep share common neural pathways. Numerous brain regions engaged in pain processing can currently affect sleep regulation. When someone has chronic pain, it's not just that it makes it hard to sleep. The pain changes the chemistry in the brain, which can change how sleep medications work. Some types of pain are caused by inflammation, and chemicals that cause inflammation can change how drugs are broken down and how brain circuits that control sleep work. When taken with sleep aids, anti-inflammatory drugs can sometimes help people sleep better by not only easing pain, but also lowering inflammation that gets in the way of normal sleep physiology. This shows why it's important to understand the whole person instead of just treating individual symptoms. Changes in hormones make sleep pharmacology even more complicated. Estrogen and progesterone, the main hormones that control female reproduction, both have an effect on sleep and how drugs are broken down. Estrogen can make some liver enzymes work better, which could change how quickly medications are broken down. Progesterone can make you sleepy on its own and make sleep medications that promote GABA work better. These hormonal changes help explain why many women notice that their sleep and medications work differently during their periods, pregnancy, or menopause. Some women find that they need lower doses of sleep medications during certain times of their menstrual cycle, when progesterone levels are high. On the other hand, when hormone levels drop, like during menstruation or menopause, you may need to take more of the drug to get the same effect. The pharmacological landscape during pregnancy is especially complicated. The physiological changes that happen during pregnancy, such as more blood volume, changes in protein binding, and changes in liver and kidney function, all affect how drugs work in the body. The developing fetus also raises ethical questions that are often more important than the medical ones. Most sleep medications cross the placenta and can have an effect on the baby's development. This means that the risk-benefit calculation is very different for pregnant women. There are problems that come up after giving birth. Taking care of a newborn can make people want to take sleep medications even more. But breastfeeding is another way that medications can affect someone other than the person who is supposed to be taking them. Most sleep aids can get into breast milk to some degree, which could change how babies sleep, eat, or grow. Changes in pharmacology that happen with age are important to pay attention to, because sleep problems tend to get worse as people get older, while the body's ability to process medications usually gets worse. Many things change as we get older that affect how drugs work. The production of gastric acid often goes down, which can change how some medicines dissolve and are absorbed. The liver's mass and enzyme activity often go down, which slows down drug metabolism. Kidney function usually declines, which makes it harder for medications that depend on renal clearance to be removed from the body. The blood-brain barrier becomes more permeable as we get older, which may be the most important thing for sleep medications because it makes it easier for drugs to get into brain tissue. This higher permeability, along with changes in brain chemistry and receptor sensitivity that happen with age, means that older people often feel stronger effects from the same doses of sleep medications. A dose that is right for a 30-year-old could make a 70-year-old confused, fall, or become too sleepy. Changes in body composition that happen with age also change how drugs are distributed. As people get older, they usually have less muscle mass and more fat tissue compared to their total body weight. A lot of sleep medications are lipophilic, which means they tend to build up in fatty tissue. This makes a reservoir that can make the effects of the drugs last longer. An older person may feel the effects of a sleep medication for a much longer time than a younger person, and they may even feel sleepy or have trouble thinking the next day. Polypharmacy, or taking more than one medication at the same time, is especially important for older adults because they are more likely to have several health problems that need different treatments. The more medications you take, the more likely they are to interact with each other. Sleep aids can interact with a lot of other drugs. Blood pressure medications, heart medications, antidepressants, pain medications, and even over-the-counter supplements can all change how sleep aids work or be changed by them. Some of these interactions happen when drugs are broken down in the body, when different drugs compete for the same liver enzymes or transport systems. Some happen when drugs work together, like when drugs with similar effects can make you too sleepy, or drugs with opposite effects can cancel each other out. Some medications have indirect effects, like a sleep aid that affects kidney function, or a drug that affects liver function and changes how sleep medication is broken down. The pharmaceutical industry has responded to these challenges by creating more advanced drug design and delivery systems. Most new sleep drugs are made to be selective for certain receptors, which means they only affect certain GABA receptor subtypes. This helps reduce side effects while still helping people sleep. Some of them have dual-layer tablets that release the medicine at 2 different rates, which helps you fall asleep quickly and stay asleep. Sublingual formulations, which are medicines that dissolve under the tongue, are good for people who have trouble swallowing pills or who need quick action. These avoid the unpredictability of gastric emptying and first-pass liver metabolism, which makes absorption more predictable and effects happen faster. They're very helpful for taking in the middle of the night, when someone wakes up and needs help going back to sleep without having to wait for a pill to pass through their digestive system. Orally disintegrating tablets are another new way to deliver sleep medications. These formulations dissolve quickly in the mouth without water, making them easy to use at the bedside and possibly providing faster effects than regular tablets that need to be swallowed and absorbed through the digestive system. Some have flavor enhancers or sweeteners to make them taste better. Knowing that how the medicine feels can affect both how well it works and how likely people are to take it. Another way to deliver sleep medication is through transdermal patches. These patches stick to the skin and slowly release medication, keeping drug levels steady all night long without the highs and lows that come with taking medicine by mouth. The skin absorption skips the digestive system completely, so there are no problems with food interactions or stomach issues that could affect how well oral medications are absorbed. The most advanced pharmaceutical technology is the creation of drug delivery systems that can respond to biological signals. Researchers are looking into implantable devices that could release sleep medication when certain physiological signs of wakefulness are present, or oral formulations that only dissolve when certain pH or temperature conditions are met. These systems are meant to give medicine exactly when it's needed, so that people don't have to take it when they don't need it, and the therapeutic effects are as strong as possible. Pharmacogenomics, which looks at how genetic differences affect how drugs work, is being used more and more in sleep medicine. Testing for certain genetic variants that affect how drugs are broken down can help you guess how someone will react to certain sleep medications. If someone has genetic variants that make certain drugs break down quickly, they may need higher doses or different drugs. On the other hand, if someone has variants that make drugs break down slowly, they may need lower doses or drugs that break down in different ways. These genetic tests aren't standard in sleep medicine yet, but they're becoming easier to find and cheaper. As we learn more about how genes affect drug response, personalized medicine that selects and doses medications based on a person's genetic profile may become the norm. This could make managing sleep medications less of a trial and error process, which would lead to better results with fewer side effects. Chronotherapeutics is another area that researchers are looking into to make sleep medications work better. This method involves giving drugs at the same time as natural biological rhythms to get the best therapeutic effects and the fewest side effects. For sleep medications, this could involve creating formulations that release the drug in sync with the body's natural circadian rhythms, or timing doses to coincide with times when the brain is most open to signals that help people sleep. Some researchers are looking into the use of light therapy along with sleep medications. They want to see if they can change circadian rhythms by exposing people to light at the right times and then using drugs to improve sleep during the desired sleep period. Some researchers are looking into how the timing of meals can affect how well drugs work and how well they are absorbed. They want to use the body's natural rhythms in digestion to make sure that medications are delivered in the best way possible. The combination of technology and sleep medication management is making it possible to create more personalized treatments. Smartphone apps can keep track of sleep patterns, when to take medicine, and side effects. This information can help you find the best dose and time. Wearable devices can track things like heart rate, movement, and skin temperature, which can give you objective information about how well you sleep and how well your medication works. Some advanced systems are being made that could change how medicine is given based on real-time feedback from the body. Think about a system that could tell when you're having trouble falling asleep and give you a small dose of sleep medication on its own, or one that could keep track of your sleep stages all night and change the levels of medication to improve the quality of your sleep while making sure you wake up feeling alert in the morning. Another important part of pharmaceutical sleep management is the link between sleep medications and cognitive function. Different sleep aids have different effects on memory consolidation, learning, and how well you think the next day. Some drugs that help people fall asleep might get in the way of the memory consolidation processes that happen during certain stages of sleep. Some may leave behind residual sedation that makes it hard to think clearly in the morning, even if the person slept well and for a long time. People whose daytime performance depends on their mental health need to know about these cognitive effects. A sleep medication that is effective for an individual with a flexible schedule may pose challenges for someone requiring mental acuity in the early morning. The timing of taking the medicine, the type of medicine chosen, and the amount taken all have an effect on these cognitive effects. New studies on sleep and brain health show that the quality of sleep that people get with medication might be different from natural sleep in ways that could affect cognitive aging and the risk of neurodegenerative diseases in the long term. Some research indicates that specific phases of natural sleep are crucial for the elimination of metabolic waste from the brain, including proteins linked to Alzheimer's disease. If sleep medications change the way sleep works in ways that slow down these clearance processes, there may be a trade-off between short-term sleep improvement and long-term brain health. But this research is still changing, and the picture is not clear. Poor sleep is linked to a higher risk of cognitive decline and dementia, so drugs that help people sleep better may actually be good for brain health, even if the sleep they help people get is different from natural sleep. The key is probably to find ways to get enough sleep while keeping the most important parts of natural sleep architecture. While the biological story may seem more important than the economic side of sleep pharmacology, the economics of sleep pharmacology actually play a big role in how medications are made and how easy they are to get, which can have an effect on patient outcomes. It costs a lot of money, often hundreds of millions or even billions of dollars, to make new medicines. This cost has an effect on which drugs are made, how much they cost, and how easy they are for patients to get. Generic drugs are cheaper than brand name drugs, but they may not always work the same way as the original. Even if the active ingredient is the same, small differences in inactive ingredients, manufacturing processes, or how the drug dissolves can sometimes cause differences in how well it works or what side effects it has. Before sleep medications can be sold, they have to go through a long process of testing to make sure they work and are safe. However, the groups of people who are tested in clinical trials may not fully represent the range of people who will eventually use the medications. Older adults, individuals with multiple medical conditions, and those on polypharmacy are often inadequately represented in clinical trials. However, These demographics frequently utilize sleep medications and may exhibit distinct responses compared to the healthier, younger populations typically examined in research. Post-marketing surveillance, which keeps an eye on side effects and effectiveness after drugs are approved and widely used, gives us ongoing information about how drugs work in real-life situations. Sometimes effects that weren't clear in clinical trials only show up when a lot of people with different traits and situations take the drugs. The fact that drugs are made all over the world makes it even harder to make sure they are of good quality and consistent. One country might make the active ingredients, another might mix them into finished products, and a third country might ship them all over the world. Different countries and manufacturers may have different standards for quality control, manufacturing processes, and regulatory oversight. This could mean that the quality or effectiveness of medications is different. People are starting to realize that the environment is an important factor in making and getting rid of drugs. A lot of medicines go through the body without changing much and end up in water systems through sewage treatment plants that aren't made to get rid of pharmaceutical compounds. Some sleep medications have been found in drinking water and surface waters at very low levels. This raises concerns about the possible effects on the environment and human health of widespread pharmaceutical use. Finding ways to make pharmaceuticals more environmentally friendly and better ways to get rid of them and treat water are ongoing problems that affect public health, environmental protection, and pharmaceutical policy. As we near the end of our journey through the world of sleep drugs, it's worth thinking about how complex the interactions we've looked at are. From the time a pill dissolves on your tongue to the time your kidneys get rid of it, every step involves complicated biological processes that have been fine-tuned over millions of years of evolution. We have essentially taken over these old systems that were originally made to process nutrients and natural compounds and changed them to help us get better sleep in today's world. The story of sleep pharmacology is really about how chemistry and biology work together, how people come up with new ideas, and how they respect the body's own wisdom. Each drug is the result of years of research, thousands of hours of lab work, and the combined knowledge of many scientists, pharmacists, doctors, and patients who have helped us learn more about how these amazing compounds work. Responses to sleep medications are wonderful, though sometimes frustratingly different for each person. One person may have no problems with a certain drug at a certain dose, while another person may have side effects. This is not because the drug or the person is bad, but because human biology is so complicated. We all have different genes, life experiences, and physical traits that affect how drugs work in our bodies. This difference isn't a problem that needs to be fixed. It's a sign of how different people are, which means that medication management needs to be tailored to each person. The best sleep medicine for you is the one that works with your body, your situation, your needs, and your preferences. To find the best way to do things, you and your healthcare providers may need to be patient, watch carefully, and work together. The future of sleep pharmacology looks even more personalized and advanced. Genetic testing might help figure out how different people will react to certain drugs. Advanced drug delivery systems might give doctors more control over when and how medications are released into the body. A better understanding of circadian rhythms could lead to timing strategies that make treatments work better and cause fewer side effects. The future of sleep medicine may be an integration, which means combining drugs with behavioral therapies, changes to the environment, and changes to daily habits to treat sleep problems in a complete way. Medications can be useful in this integrated approach, but they work best when used carefully as part of a larger plan for getting good sleep. As you drift off to sleep tonight, whether on your own or with the help of drugs, remember that you're taking part in one of the most basic biological processes. Sleep isn't just not being awake, it's an active, restorative state that lets your body and mind heal, store memories, control emotions, and get ready for the challenges of the next day. The drugs we've talked about tonight can help this natural process when it's interrupted by illness, stress, aging, or the demands of modern life. They work by changing or improving the same neural pathways and chemical systems that naturally help you sleep. This helps bring back the balance between being awake and resting that is so important for health and well-being. Knowing how these drugs work in your body gives you more power to use them safely and effectively. You can make smart choices about when to take your medicine if you know that food affects absorption. When you know that each person's genetics affect how they respond to drugs, you can work more patiently and methodically with your healthcare providers to find the best ways to treat you. When you understand how complicated drug interactions can be more careful about mixing medications or supplements. Understanding the science behind sleep medications is the most important thing you can do to understand what they can and can't do. They can help a lot with sleep problems, but they're not magic. They work best when they are part of a full plan for good sleep that includes taking care of your sleep hygiene, managing your stress, staying physically healthy, and paying attention to your surroundings. The way a sleep medicine moves through your body, from absorption to distribution, metabolism, action, and elimination, shows how well all of your biological systems work together. Your digestive system takes in food, your cardiovascular system sends it around, your liver changes it, your brain reacts, and your kidneys get rid of it. It's a symphony of biological cooperation that happens mostly without our knowing it, but it's one of the most advanced chemical processing systems in the universe. As consciousness slowly fades and sleep takes over, take a moment to appreciate how amazing this biological process is. Whether you fall asleep on your own or with the help of drugs, it means that many molecular interactions, cellular processes, and organ system functions are all working together to give your body and mind the rest they need. Sleep well, knowing that the field of pharmaceutical science and human biology is always changing. This gives us hope for better treatments and a better understanding of one of the most important processes in life. You're part of a story of scientific discovery and human healing that has been going on for hundreds of years and will continue to do so in the years to come. This story is happening while you sleep, and your medications work their magic. Have a good night's sleep, and may it be deep, restful, and peaceful, thanks to the amazing combination of chemistry and biology that makes sleep aids possible. The night is yours to heal, restore, and go through the mysterious but necessary process of sleep that gets you ready for the adventures of the next day.